I'm presenting our experience with the supraorbital mini craniotomy. The minimally invasive approaches started with the technical note by John A. Jane in 1982. And Pernesky and Joe and all have contributed to its popularity and usability. I learned this from Professor A.K. Singh, whom I assisted when he utilized this approach to clip an ACOM and an MC aneurysm in a patient at the microneurosurgery workshop. This is a study of about 20 plus patients, and we want to evaluate the reason why it has not been used more often. Conventional approaches we are all very familiar with, and we have got large numbers of patients and we utilize it, but it has a significant parenchymal shifts. It has got a lot of retraction. The time is obviously much less in this, but large reviews feel that the complication associated with both are comparable. Majority is still the conventional familiarity, usability, instrumentation used, and it allows for a careful repair of the dura with large vascularized pericranial flaps. The working arc, the angle of attack, special instrumentation needs, cosmesis, frontal sinus breach, and resultant CSF rhinorrhea are some of the many factors that conflict with the Pernesky's keyhole concept that a surgical approach should be as large as necessary and as small as possible. Decision making is complex, but we utilize these approaches in specific patients, and the limitations of both approaches are the narrow corridor. We study the radiological individual anatomy, the tumor specifics, whether the olfaction is preserved, and need for retraction in case of large edema. We have the usage of conventional microsurgical instruments, bayonet shape with some specialized clip applicators for aneurysm surgery are needed. Neuronavigation is a great asset, and obviously microscope is indispensable. And neuroendoscopes are to look around the corners. We have still not sort of evolved to full endoscopic excisions. Hooks and rubber band retractors are conventionally used. So this is our normal incision. And as you can see with the retractors, rubber band based retractors, we are able to increase the amount of bone which can be removed. Both conventional approaches also use a smaller bone. Use of drills made this possible. An osteoplastic flap, as you can see, is possible, but it is fragile. Now, this is the approach, as you can see in a short video, where you can see that the midline is easily reached. There is adequate visualization. There's no need of significant retraction, and you are able to utilize and do the maneuvering quite well. The visualization is increased with the microscope, and the biggest problem in this approach is the closure of the dura, where you can miss sometimes. 20 to 30% of leaks can be missed. 20 to 30% risk of meningitis is there. And obviously, that if meningitis develops, then the risk of mortality is high. In our series, you had patients ranging from 12 to 69 years, and all like secondaries, meningiomas, midline lesions, lesions to one side with significant peritoneal edema. We have had a lot of the meningiomas. This was a pituitary adenoma. We initially thought that it could be a meningioma, but yeah, it had a very soft and suckable, and we were able to achieve. The comfort of the patient and the cosmetic outcomes are very good in this patient. Patient's recovery tends to be faster. And as you can see that immediate post-operatively, the patient's comfort level are definitely more than they think. This is a boy with a craniopharyngioma. And as you can see, with a very good radical excision of the lesion. So these are the various pathologies which we have tackled using this. This is a frontal tuberculoma, which you use this approach in a young lady. The pure endoscope is possible, but we have to build more experience with this. And this probably will become the standard for removal of the meningiomas and craniopharyngiomas of this level. The patients, 95% in large series have had very good cosmetic results, but sometimes this can be an issue, but we have to learn for the facial maxillary surgeons how to do this. CSF leaks should be very well studied, and we should take all the precautions to avoid this. Tumor resection was radical in most. One approach was abandoned because it was attempted by residents, and we had to convert it into a major thing. We have to watch out for pneumatization, adherent dura. Navigation definitely helps, and we should stay lateral. Wound leak was in 2, CSF rhinorrhea in 1. Leak repair had to be done. One patient succumbed to meningitis. One patient with a craniopharyngioma had significant scarring in his face, and he required a plastic procedure. As Pernesky demonstrated, large tumors can be removed by this approach, and it is something which grows on you. And I'm really fond of this approach, but it does take a lot of experience to get good results. Thank you.